Hello, this is Erica Dorr, Associate Director at the North American Thrombosis Forum. I'm here with Dr. Christian Ruff, cardiologist at Brigham and Women's Hospital and clinical trialist at the TIMI Study Group. Dr. Ruff will be a speaker at this year's 7th Annual Thrombosis Summit on September 28th. Good afternoon, Dr. Ruff.
Great, thank you, Erica. Pleasure to be here.
Thank you for taking the time to speak with me. Dr. Ruff, you will be covering the topic novel oral anticoagulants for stroke prevention and atrial fibrillation, and I would like to take this opportunity to ask you a few questions.
Terrific.
Okay, what are the clinical consequences of atrial fibrillation?
So atrial fibrillation is the most common electrical disturbance that we encounter in clinical practice. It's truly an epidemic, with tens of millions of patients in the United States alone who suffer from this condition. And although predominantly patients with atrial fibrillation initially present to clinical attention with symptoms of shortness of breath, palpitations, potentially even heart failure, the real complication, and the one that I'll be addressing in my talk, specifically refers to the dramatically increased risk of stroke. And we know in patients with atrial fibrillation they can form blood clots in the heart, and those clots can be ejected from the heart and go into the bloodstream. And unfortunately, the first big organ that those clots see is the brain. And so atrial fibrillation is a major cause of devastating strokes. And you could also get clots to other parts of the body, but stroke remains one of the biggest and most feared complications of atrial fibrillation.
What are the differences between novel oral anticoagulants and vitamin K antagonists such as warfarin?
It's a great question, and we know for many decades now that antithrombotics, specifically anticoagulants or blood thinners, are the main treatment options available to reduce the risk of stroke in patients with atrial fibrillation. Warfarin, which is a vitamin K antagonist, has been in clinical use for over half a century. In fact, it was first approved in 1954. And it remained the only oral anticoagulant we had at our disposal until the last several years, which is pretty incredible when you think of the rapid advances in medicine. Now, although warfarin is extremely effective in reducing stroke, it is one of the most difficult and potentially dangerous drugs that we use in clinical practice. It has a very narrow therapeutic index, and it requires individual monitoring for each patient. You can't simply give a dose and that works for everybody in your practice. You have to tailor the dose to a specific patient by measuring blood tests, the INR, or International Normalized Ratio, and try to keep it within a narrow range of 2 to 3. Because when we know when the INR is below 2, patients are at increased risk of stroke. When it's above 3, patients are at risk of increased bleeding, particularly intracranial hemorrhage, which is the most feared and devastating complication of atrial fibrillation. Warfarin also has many interactions with food and hundreds of other drugs. So it becomes very challenging because most patients with atrial fibrillation are older, and elderly people tend to have more comorbidities and are on other medications, and warfarin frequently interacts with those medications. And so it's really been a good fortune that through interactions with the pharmaceutical companies and academic research institutions that there have been several breakthrough advances where we have new oral anticoagulants called NOACs, or novel oral anticoagulants, that are now available as potential replacements or substitutes for warfarin. They come in 2 distinct classes. One are the direct thrombin inhibitors, which inhibit the coagulation cascade distally, and then the factor Xa inhibitors, which inhibit factor X, which is more upstream in the coagulation cascade. There are several agents available and others that may soon be approved, and they have been shown in groundbreaking, very large clinical trials to be as effective and potentially more effective in reducing ischemic stroke in patients with atrial fibrillation. One of the most dramatic differences, though, was unanticipated. That although these drugs were designed to reduce ischemic stroke, they seem to be particularly beneficial on the safety aspect. And it's not clearly understood why, but they dramatically decrease bleeding in the brain. And so when we look at all of the trials with the novel oral anticoagulants, they dramatically cut in half approximately the risk of hemorrhagic stroke and intracranial hemorrhage in general. And this is really outstanding because we know one of the most dangerous complications of anticoagulant therapy is the risk of intracranial hemorrhage, because intracranial hemorrhage is often fatal, and if not fatal, leads to permanent neurologic devastation. And so this is really a big difference between all of the oral new anticoagulants and warfarin. Another important difference, and these drugs were designed not to need routine monitoring. So unlike warfarin, which requires periodic blood testing, these agents don't require any specific monitoring. They're also very quick acting. We know if you start taking warfarin, it may take several days, in fact, potentially in some patients, several weeks until they're fully therapeutic on warfarin. These new agents, within taking a single pill, they may be therapeutic within 2 to 4 hours, so very rapidly acting. And they also, though, have a shorter half-life. If you stop these medicines, within 1 to 2 days, most of the anticoagulant effect is gone. Whereas warfarin, we know that even if you stop warfarin for several days, you may still have a therapeutic effect. I think another important difference to point out to both patients and clinicians is that all of these drugs have some degree of renal clearance. And so they are not to be used in patients with severe renal dysfunction, particularly those who have end-stage renal disease or on dialysis. Warfarin remains the only drug that is indicated for those patients. And we do have to be careful with these new agents when using them in patients with significant renal dysfunction or who have worsening renal dysfunction. And so some of those are the main differences, and I hope in my talk I'll highlight some of the other important differences between the individual novel oral anticoagulants and also differences between warfarin in general.
40% of patients with atrial fibrillation who should be anticoagulated are not receiving anticoagulants and are highly susceptible to stroke. What are some of the contributing factors to the reluctance of clinicians to anticoagulate patients with AF?
Yeah, it's a great question. It really highlights one of the big failures, I think, in the medical and healthcare community, that many patients who are at risk for life-threatening stroke, which leads to either death or tremendous disability, are simply not treated. And it's a staggering figure, and we know that we haven't made much progress in this area in decades, even though it's been recognized for a very long time. When you poll physicians and you ask them why are they not anticoagulating patients who seem to have no contraindication to anticoagulation, at least no rigid contraindication, most of them will say that they are concerned because that patient is frail and at risk for falls. And in very nice studies, I think the evidence is accumulating that we tend to dramatically overestimate the risk of bleeding in frail patients or those risk of falls. In fact, in some interesting modeling data, it showed that a patient would have to fall approximately 300 times a year before the risks of anticoagulating would outweigh the benefits in reducing stroke. And in other studies where they had physicians evaluate patients and determine whether they were high or low risk of falls, it didn't appear to affect their risk of long-term bleeding if you followed them out for a year. And in fact, in patients that did fall, very few bleeds occurred. And so I think that there's a pervasive fear that elderly patients who maybe have a mechanical fall every once in a while should not be anticoagulated. I think we're grossly overestimating that most patients, even if they're frail and occasionally fall, we should be anticoagulating. It's safe to do so, and the risk of very serious bleeding tends to be very, very low. That doesn't mean that there are some patients who an anticoagulation may not be appropriate, particularly patients who've experienced serious life-threatening bleeding, particularly intracranial bleeding or spontaneous bleeding. Those may be patients who anticoagulation is not appropriate. But I think in most patients, we can do things to mitigate their risk of bleeding. We know that using an anticoagulant with antiplatelet agents dramatically increases the risk of bleeding. And so we should review patients' medications, and if we can remove an aspirin or a clopidogrel or potentially non-steroidal anti-inflammatory drugs, we may dramatically lower their incidence of bleeding while protecting them with an anticoagulant for their risk of stroke. And it's been shown in very nice studies that by using an anticoagulant, these studies were done against warfarin in that day and age, that you'd reduce about 35 ischemic strokes for causing one serious bleed. And so I think that is a very healthy benefit for warfarin, and I think we have to be more and more comfortable that anticoagulants are generally safe in the elderly.
Well, thank you again for taking the time to speak with me. We are truly looking forward to the summit in September.
Great, thank you. I'm looking forward to participating. See you then.